Assalamu alaikum jami'an. First of all, I would like to thank the organizing scientific committee for having me today and to giving me the chance to present our abstract titled Insight into Chronic Non-Bacterial Osteomyelitis in Pediatric Patients, a comprehensive study from multiple centers in Saudi Arabia. So I have no any financial disclosure or conflict in my presentation. Let's start with a brief background. CNO, chronic non-bacterial osteomyelitis, it's a sporadic autoinflammatory bone diseases that mainly affect the children and adolescents, and they typically chronic conditions with a broad spectrum of clinical presentation, ranging from a mild self-limited disease, monofocal, monophasic, to a chronically active and severe recurrent multifocal bone lesions, or so-called CRMO. The typical main feature is a nocturnal localized bony pain with or without associated bone swelling or fever, and the bone culture is always sterile with no responses to antibiotics. To date, there is no any validated diagnostic criteria for CNO, and there is no widely accepted tested diagnostic criteria. So it's a diagnosis of exclusion of other mimickers and potential differential diagnosis. Moreover, there is no any drug approved for treating CNO. There is no like a high-powered clinical trials that assess the efficacy and the safety of medication for CNO. So most of the time they're treating CNO patients empirically and based on personal experience, expert opinion, case reports, and some case series. However, CARA initiatives in 2018 proposed a 3 consensus treatment plan in case of NSAIDs failure or spinal involvement. They aiming to standardize the medications and to assess the treatment response for research purposes. So we noticed that the treating physicians in Saudi Arabia, they face a really significant challenges and difficulty due to the lack of epidemiological data for CNO. So our study is designed to examine and assess the phenotype and baseline characteristic of CNO, including demographic data, clinical symptoms, laboratory findings, imaging modality, bone biopsy, medications options, as well as the clinical outcome. So it is observational retrospective cohort and clinical records of 58 patients under the age of 16 years who were diagnosed with CNO between 2015 and 2021 at 6 centers in 3 major cities, including Riyadh, Jeddah, Mecca, were reviewed. And we have found the following results. So as you can see here in this table, the mean age at diagnosis were 8 years plus or minus 2, and it is predominantly female, about 2/3 of our patients in comparing to male gender. Moreover, if you can see here, then the bone pain considered the most MSK manifestations, followed by the bone swelling and arthritis. Only 14% of our patients developed fever as a systemic manifestation associated with CNO. Moreover, family history of autoimmune diseases was noticed in 9% of our patients, and it's included type 1 diabetes, hypothyroidism, rheumatoid arthritis, and only 2 of our patients, they do have a family history of CNO. Moreover, regarding laboratory findings, interestingly, the ESR elevation found in 85% of our patients in comparing to CRB positivity, 42%. And only 1 patient from the 58 had positive HLA-B27. Almost 2/3 of our patients underwent the bone biopsy, and it showed a histopathological evidence of osteomyelitis with negative for malignancy and infection. So as you can see here in the chart, the light purple, so the multifocal pattern considered the most dominant pattern in CNO in our population, and only 1/4 of our patients develop monofocal disease. The most commonly involved site were the lower limb bones that include the femur, the tarsal bone, the metatarsal bone, tibia, fibula, followed by pelvis, clavicle, and upper limb bones. And only 16% of our patients develop spinal involvement. Moreover, regarding the imaging modality, we know that the whole body MRI considered the gold standard imaging modality, as a 30% of CNO patients develop a clinically silent active lesion. And the important here is this active lesion could be located in the high-risk critical areas as vertebral bodies, hips, or growth plate. However, if you can see here, the X-ray considered the most utilized imaging modalities with 85%, followed by regional MRI 71% and bone scan 57%, and whole body MRI only in 1/3 of our patients. Of course, this is due to multiple factors, including the accessibility, the availability of the whole body MRI, in addition to the safety concerns for the children by putting them under sedation and general anesthesia, as well as the cost effect. So in terms of medication and clinical remission, if you can see here in this graph, the blue bars, NSAIDs considered the most used medications, and usually it is the starting medication unless there is a spinal involvement, followed by bisphosphonate, 57%. And interestingly, you can see here that anti-TNF, I don't know, yeah. Anti-TNF or biological DMARS utilization was almost 40% in our patients. And this is considered a very high rate in comparing to what was mentioned in the literature due to multiple factors. One of important, it's maybe reflect the high rate of the refractory cases that managed to escalate the treatment to use biological DMARS. On the other hand, you can see here the methotrexate has been used with steroid as a bridging therapy. Anti-IL-1 administered to 2 patients who suspected with monogenic autoinflammatory bone diseases with good response, and anti-IL-6 for a patient who developed a hip arthritis that failed anti-TNF. So regarding the clinical remission, the overall outcome, almost 84% of our patients received a clinical remission. However, we try to correlate the clinical remission for each single medication, but it's really difficult because there is it's only like a 58 patients, a small sample size, with really heterogeneity of management between the physician and the institution. So you can see like an overlap effects. We don't know which of which induced the remission in this study. So that leads me to my next point, which is the limitations and future consideration. A recent study from Saudi Arabia, recently published, focused on the diagnosing and treating CNO among the pediatric rheumatologists, and it showed significant variability in terms of approaches and management of CNO. Which emphasize the need for a standardized guideline to be established in our area. Hopefully, the data that we obtained from our study, in addition to what have been mentioned in the previous findings, we help to develop a local consensus to treating this rare entity in Saudi Arabia. So, in conclusion, our data is consistent with previously studies in terms of phenotype and laboratory characteristic of CNO. Biological utilization in our patients was more than what was mentioned in the literature, indicating the high rate of refractory cases to conventional therapy. We observed an overall positive outcome with most of the patients achieving clinical remission, and our cohort, again, as I mentioned, is a step toward developing a local consensus to standardize the CNO treatment for our patients. Finally, I would like to thank all the co-authors who participate and contributing on this project, and thank you so much.
Thank you, Dr. Lujain, for this excellent abstract. Any question, please, before we move on?
Thanks, Lejane. That was really great presentation.
Thank you.
I'm just wondering, because if you go back to your treatment slide,
Sure.
30% of your patient required steroids. So I'm wondering, was that due to the bone symptoms, arthritis, and was it like oral systemic steroid or intraarticular steroid? Because it's a bit weird for me, like getting steroid.
Yeah, yeah. So regarding the methotrexate and steroid, you know that one of the proposed, CARA guidelines or the treatment pathway, it is using of conventional DMARDs. Sometimes the biological DMARDs and bisphosphonates not been available, and this is an alternative we have been used or noticed in even the private sector. If there is no any biological DMARDs or bisphosphonate, they use a methotrexate and steroid as a bridging therapy. It is not that great, I know, alternative with its questionable efficacy and induce a very low induced remission rate, around 20%. But this is our observation in our study.
Thank you, Dr. Lejane.
Dr. Sadiq? Yeah.
A lot of people are now moving away from bisphosphonate to anti-TNF. I'm sure because of safety issues. So in my practice, I would start NSAIDs, and if I fail, I go to anti-TNF. I don't use bamidronate anymore. So I don't know what is the feeling on the audience, but even internationally, a lot of people are moving away from bisphosphonate and choosing anti-TNF.
Yeah.
So I think your data reflect what is happening all over the world, actually.
Yeah, thank you, Dr. Sadiq. I think in our study, we're comparing our result with the largest Eurofever data registry. If you remember that they included 500 patients worldwide. Even there is a patients from Saudi Arabia. So overall, utilization of biological DMARD and that very large, huge registry for CNO, 7%. So 40%, I think we do have, high rate of utilization of biological DMARD. The other thing that the availability. So not all, the worldwide, they do have an easy access to biological DMARD. So maybe that's a kind of, factor. That's why we utilize it more. In addition to the refractory cases.
Alhamdulillah, reflects how lucky we are.
Thank you so much.
Thank you, Dr.
Alhamdulillah.